We're going to look here at the initial approach to the newborn, and this is all the stuff that needs to be done within the first couple hours of life. So a lot of this is done in the delivery room or in the nursery right away. This is not the comprehensive physical exam that you do on the baby, the nursery exam. This is just the stuff that's done right away to see if there's any immediate problems that need to be addressed emergently. So we're going to go over some stuff that's important to know that'll come up on the test that can lead you to the suspicion of possible problems with the baby immediately. So the maternal and paternal medical and genetic history, the maternal OB history, the history of the labor and delivery, and then the assessment of the gestational age and size. We'll talk about growth abnormalities and what those can lead to, what can cause them, as well as Apgar scoring, which is very, very important. It's basically your most of your physical examination that's done immediately for the newborn. We'll talk about some other things that are also done at the birth examination to look for any problematic signs that warrant immediate attention. And then we'll also talk about the immediate newborn care, which is done for all babies. So as far as history, you'll want to know about mom and dad's medical and genetic history, but particularly mom's. So it's important to know if dad has any congenital anomalies in his family or anything with genetic implications, as well as knowing that on mom's side as well. But you definitely need to know more about the maternal medical history more than the paternal history. So on the maternal side, you need to know about congenital anomalies, but you also need to know if there are any medications that were taken during the pregnancy. Particularly, we're looking at teratogens. One thing that stands out to me would be looking at anti-seizure medications, because those are typically continued during the pregnancy, and they're also teratogenic. Now, they're continued because the risk of harm to the baby if the mother has a seizure is much greater than the risk of the medication in general. So while those medications are teratogenic, they're continued, but you need to know if mom was taking those medications or any teratogenic medications during the pregnancy. You need to know about mom's dietary habits. If she is a vegetarian or a vegan, she might not have been getting the appropriate nutrients. That's not to say that vegetarians and vegans are, bad with their nutrition, but any unique dietary habits that the mother has, you'll want to know about that. Also, if she's on a calorie-restricted diet, you'll want to know that as well. If she smoked or drank alcohol at any point during the pregnancy, you'll want to be aware of this. We tell mothers not to, or expectant mothers not to smoke or drink alcohol during pregnancy, but it doesn't mean that they abide by it. So smoking can lead to clots and problems with the placenta. Alcohol can lead to fetal alcohol syndrome. You want to be aware of that. Also, any occupational or environmental related risks. So this has a wide range, but like medical personnel, if there's any exposure to radioactive chemicals, certain industrial occupations, strenuous labor, farming, exposure to cats, veterinary exposure. And then you also want to know if the mom has any chronic medical conditions. Particularly here we're looking at diabetes. That can lead to a large baby, hypothyroidism, hypertension, autoimmune disorders, and infections, especially those torch infections, including HIV. If the baby is born to an HIV mother, then there are precautions that you'll want to take, and you'll also want to get an HIV test on baby right away. You want to know about the mother's overall obstetrical history. So on the USMLE and in real life, a lot of times you'll be given this gravida para thing. And the gravida para just means gravida, how many pregnancies she's had total, para, how many deliveries she's had. So gravida is total pregnancy. This can also be broken down into the GTPAL status. If you look at an obstetric note, they'll probably use this GTPAL system. However, on the USMLE, they tend to use the gravida para system. GTPAL is just more in-depth. So gravida is total pregnancies. Term is pregnancies delivered at term, defined as 37 weeks of gestation or longer. Preemies is anything less than 37 weeks delivered. Abortions is spontaneous or elective abortions, and then living children. So this would be G4, T3, P0, A1, L3. for instance, meaning that mother has had 4 total pregnancies. She had 3 pregnancies delivered at term, no preemies, 1 abortion, either spontaneous or elective, and 3 currently living children. So that's an example. You want to know the mother's blood type, especially her Rh status. If the Rh status was incompatible with the baby, whether or not she received prophylactic RhoGAM. Rh isoimmunization is a major problem if it's not addressed. Past pregnancy outcomes are important. Details if there were problems. You want to know about the history of the current pregnancy. If there are any abnormal sonographic findings. Any results from routine screening tests. There's a lot of those that are done. So HCG, nuchal translucency, torch titers, pap smears, quad screens, OGTT, GBS, Rh status, lots and lots of tests that are done routinely. And then results from any amniocentesis if the mother underwent that procedure. You'll also want to have documentation of any complications during the pregnancy. So if the mother has had preeclampsia or eclampsia during this pregnancy, if there's gestational hypertension, diabetes, UTI, if this is a preterm labor, or if she had had labor preterm that was stopped with tocolytics, you'll want to know that. You'll also want to know the history of her labor, or current labor, so the duration of rupture of membranes, how long has it been since her water broke. The appearance of the show, was it bloody, was there meconium? That's important. Typically when you see meconium in the show, it's a post-term infant. The meconium will, if it's present, can increase the risk of meconium aspiration syndrome, which is a respiratory problem, and that's going to cause problems for the baby. So you want to be aware of that. Does the mother have a fever? Is the baby in distress? Usually fetal distress will be picked up on by the fetal heart rate. The fetal presentation. So was it a cephalic presentation? Was it a breech presentation? If it is a breech presentation, typically the obstetrician is going to have to employ some aggressive maneuvers, and those are problematic because they can lead to injury to the baby. So applying extra traction or using different techniques that would be necessary to deliver the baby, they can injure the baby, which is bad, but you also have to get the baby out. That's important too. You want to know the mode of delivery. Typically this is obvious, but was it a vaginal delivery? Was it a C-section? Was there any use of instruments like vacuum or forceps? The vacuum definitely increases your risk of a subgaleal hemorrhage, and forceps can cause injury as well, so you want to be aware of that. Was there any anesthesia used during the delivery? Anesthesia can reduce the infant's respiration. And so that's good to be aware of. And then finally, last but not least, the Apgar score, which is a very, very, very critical testing to do on the newly born infant. It should be done 1 minute and 5 minutes after birth. And I'll show you what the Apgar score is and what it means and doesn't mean. You want to know the gestational age and size. So big babies, small babies, abnormally big or abnormally small, they both face a unique set of problems, so you want to be aware of this. Now, the most reliable indicator of the baby's gestational age is by using the date of the last menstrual period. However, not all women know when their last menstrual period was. So there's other things that you can use, such as sonography, measuring the baby, but as mentioned, there can be problems in which the baby doesn't grow appropriately, and so the gestational age, if it's measured just based on size on sonography, might not be correct. So that's why the last menstrual period is the best indicator. But if you don't have that, you can use sonography. After the birth, you can also use criteria. The Ballard method is commonly used. However, you do not need to be aware of how to use the Ballard method on the USML. So the baby's birth weight is also important, and this is just for looking at possible problems. So is there a low birth weight or is there a high birth weight? The normal birth weight range is from 2.5 kilograms to 4 kilograms. So if the baby is less than 2.5 kilograms or 5 pounds 8 ounces at birth, then it's considered a low birth weight. And there's also a range for very low birth weight, but you just need to be aware of what's low birth weight, and that's less than 5 pounds 8 ounces or 2.5 kilograms. High birth weight would be anything more than 4 kilograms or 8 pounds 12 ounces. And then finally, the baby's size relative to gestational age. So this can be plotted down on a chart, and that'll show you the percentile. You look on one axis, which will give you, you plot the gestational age, and then another axis where you plot the size, and then you draw the lines, connect them, and it shows you the percentile. Please note that small for gestational age is not a synonym for low birth weight. So most premature babies are low birth weight, but not all low birth weight babies are premature. So if you have a baby who is premature, they're probably going to be small when they come out because they're premature. And so they will be a low birth weight. Low birth weight just means the baby was born less than 2.5 kilograms. But if the baby is premature, they may be perfectly normal for their gestational age. So small for gestational age implies that there is a problem in growth. The baby is small for their gestational age. And typically that's a low birth weight baby as well. But a low birth weight baby is a baby who's small at the time of birth. Even though they may not be small for gestational age. So you may have a 2.1 kilogram baby that's premature, and that's not a small for gestational age because the baby is premature. It hasn't finished developing yet, and it's been prematurely developed. So it's not small for gestational age, but it is low birth weight because low birth weight is defined simply on weight alone. Small for gestational age is defined as the weight relative to the gestational age. So the growth abnormalities, babies who are small for gestational age, they are at increased risk for fetal distress, hypoglycemia, polycythemia, and hypocalcemia. You want to know if the baby is small for gestational age, is the reduced size symmetrical or is it asymmetrical? If the defects are symmetric, if the baby's just overall small, that's associated with problems early on in the pregnancy, early birth problems, early pregnancy problems, I guess it should say. So that can be something like an intrauterine viral infection, particularly cytomegalovirus, chromosomal anomalies, that's going to be very early on at conception, and maternal drug abuse. Asymmetric defects are associated with late pregnancy problems. So placental insufficiency, and that can happen from gestational hypertension, maternal vascular disorders, which will cause ischemia to the placenta, an older maternal age, more than 35 years of age, poor weight gain during pregnancy, and multiple gestation. So this is Virginia Apgar. She was an American obstetrical anesthesiologist, and she is credited for coming up with these criteria and this scoring system to determine whether or not the baby is responding to resuscitative care. So, the Apgar score is taken at 1 minute after birth and also at 5 minutes after birth. And what the Apgar score is an assessment of the baby's response to any resuscitative efforts if necessary and the baby's present status. But it is not a predictor of long-term outcome. The Apgar score also is likely correlated to the baby's risk of developing necrotizing enterocolitis. And necrotizing enterocolitis is a GI disease, a surgical GI disease. It's emergent, it's deadly, and it happens in premature babies. So if the baby has poor Apgar score and is premature, that baby is likely at a higher risk for NEC. So how do we do the Apgar score? The Apgar score is easily computed just by pretty much by looking at the baby and auscultating the baby. So You assign, there's three different categories that these can be in, and they're scored 0, 1, and 2, and there's 5 different things you're looking for. So first off, you look at skin color, and that's pretty easy to do. Usually when the baby's first born, when you're pulling the baby out, the baby is going to be blue. But after about a minute, the baby should be pink. So if the baby's cyanotic still, that's going to be a score of 0 for skin color. If the baby's body is pink, the limbs are cyanotic, that's a score of 1. And if the baby is pink completely, that's 2. You listen to the baby's pulse. If it's absent, that's of course a 0. If the baby's pulse is slow, and remember here we're dealing with pediatrics, with babies, and so the range, the normal range, is a little bit different than it is for adults. Slow is defined as less than 100, whereas in adults, anything greater than 100 is abnormally fast. So if it's slow, less than 100, it's a score of 1. If it's greater than 100, it's normal, and that's a score of 2. Then you also want to know a baby's response to stimuli. So usually this is done by placing a catheter in the nares. It's just a small catheter. And you're looking for some kind of response from the baby. So if there's no response, it's going to be a 0. A grimace, that's a 1. A cough or a sneeze, that's a 2. Muscle tone is just looking at the baby's movement. If the baby is limp, it's a 0. If there's some flexion, it's a 1. If there's spontaneous movement, that's a 2. And then finally, respiratory effort. If there's no respiratory effort at all, that's a 0. If it's slow or irregular, that's a 1. If the baby's crying, that's a 2. So you add all these together, maximum score of 10, minimum score of 0. A 0 is pretty much a dead baby for all intents and purposes. 10 would be your perfect outcome. And 0 to 4 is defined as poor, 5 to 7 is defined as fair, and 8 through 10 is defined as good. So you take this at 1 minute, and it might be a score of 6 or 5. And then you take it again at 5 minutes, and it might be 9. So if the baby was born with let's say a 3 or a 4, and you do resuscitative efforts, and then at 5 minutes, the baby's Apgar score is 8, what that tells you is that your resuscitative efforts are successful. But it's not a predictor of long-term outcome. And you can remember how to do the Apgar score based on this mnemonic. And I don't think Virginia Apgar was trying for this, but it worked out this way. If you consider skin color to be appearance, response to be grimace, muscle tone to be activity, then it comes out as APGAR, or Apgar. So again, Apgar scoring, you do at 1 and 5 minutes. Particularly skin color, what you're looking at there is a good indicator of cardiac output. So if the baby is blue still after 1 or 5 minutes, that's a problem likely in the heart, cardiac output. You also want to do a skeletal examination, particularly if the baby is large for gestational age. What you're looking for is birth trauma, especially to the clavicle or the humerus. Those are the most common areas of injury as far as the bones go. And that's because when you have larger babies, you can have shoulder dystocia. The obstetrician may need to do some maneuvers that are a little bit more aggressive, and that can injure the clavicle or humerus. So you should palpate the clavicle. Any bony abnormalities, you'll want to send that baby off for an x-ray. In the case of cesarean delivery, remember that you are using surgical steel, and that's sharp, and so it's very easy to accidentally poke the baby through the amniotic fluid, and so you'll want to look for any lacerations from instruments. Usually if they're there, they're not that severe. They can be stitched up, and you use some antibiotic ointment. But I don't think it's that common. I've never seen that happen in the couple dozen or so C-sections I've seen. Umbilical cord and placenta should be examined at some point. Typically it's done by the OB right after they deliver the placenta. And so they'll look for any placental infarctions. And you also want to look at the umbilical cord to ensure that there's 2 arteries and 1 vein. That's normal. If there's 1 artery and 1 vein, which would be an anomaly, that's associated with defects. Small placentas are typically seen in small infants, so the placenta should be roughly correlated to the baby's size. And like I said, when the OB is looking at the placenta, they're looking primarily for infarcts or clots, and that suggests that there could be placental insufficiency. Immediate newborn care. So first off, you want to attend to resuscitation or any other emergencies first. Once you've done that, and usually the nurse does this, you cleanse the skin and the umbilical cord with a warm, soft soap solution, and you'll disinfect the umbilical stump with a bacitracin ointment or a triple dye solution. You'll treat the eyes with erythromycin ointment, or you can use silver nitrate drops, and then finally you'll administer 1 milligram of vitamin K intramuscularly, and this is done for all babies.